And I want to welcome you and just say that I am honored to be a part of the Sakura FineTech educational series of webinars. I think continued development is very important in the industry for you all to continue to grow and develop as healthcare professionals, which you are. And we don't get told that as often as we should, but we are not just workers in a lab. We are not just tissue techs. We are healthcare professionals. We are histology professionals. So I want to commend each and every one of you who's in the audience today for taking this session for whatever reason. It's on what would seem to be something very basic, such as H&E staining. But in today's day and age, compliance and validation is becoming more and more of a concern, particularly at times of inspection. And it's something that we should do anyway. And actually, once you really start doing it, it really helps you validate not only your procedures, but that your patient testing is competent and validated that it works, that it's going to continue to work, and that you're monitoring that it works. So years ago, in the 60s and 70s, a lot of these things were different. We just did the stain. We took it to the pathologist, and he either liked it, he didn't like it, and we'd go back and start working on it again. Well, now validating every aspect of your H&E system is very important. Not just the stain and the dye, not even just the protocol, but even the stainer that you're using, the dyes that you're using, the reagents that you're using, how often you change those. For consistency, those need to be validated and they need to be done the same way each and every day. So that's what we're going to talk about today. Moving on to the first slide with the objectives. The first bullet point is understand the various elements of your H&E staining system, and I want to emphasize the word system, and the integral role they play in your total system validation. It's not enough to validate the stain that you're using, but you have to validate the stain in congruence with all these other things, as I mentioned before, stainer, protocol, and so forth. Second, learn the differences in transitioning from one automated stainer to another and how the protocol and or stain must be adjusted and revalidated based on staining performance. And I have people sometimes in labs try to beat me up over there. Well, you don't need to do that. It's not necessary. You're just wasting time. But your protocol that you use, even the dyes that you use, are not guaranteed to perform the exact same way from one stainer to another. There are a number of different variables, how you have it set up for rinses or how you have it set up for how many dips or agitation. All those things can affect the stain performance, whether it's going to be weak stain or a very dark stain. And I'm not saying that one stain is better than the other, but what I am saying is you should make adjustments, and or you might have to make adjustments, but you need to validate that protocol and those stains work as well for patient testing on the other stainer. The third, learn how to develop a validated stain protocol through a series of trial runs, documenting the various protocol changes from run to run, and the final protocol approved by the pathologist. Now, this can help you, and I'm going to show you how to set up a table on this, because this can help you as you try to do different things, different procedures, and you tweak this and tweak that, and you do another run, the transition from how you got to that. The fourth bullet, understand how to set up an internal quality assurance review to monitor or document the staining performance from day to day. And that's checking things like you should be running some type of control tissue slide in the first part of your run in the morning, and that's to validate that everything's working when you start it. If you run a high volume of slides, you might want to rerun that slide after maybe 700 to 1,000 slides, and then you want to actually document how many slides you ran through before you had to rotate or change the solutions. And this is to promote consistency and reproducibility in the stain performance. And it's very important when we're talking about patient tissues. And you say, well, the hematoxylin is getting a little bit light. Well, we should be on top of that. We should have up a quality control system, a quality assurance system, so that if it starts dropping off, we're kind of aware of that, like every 400 slides or every 500 slides. And so finally, the last bullet, learn the necessity of documentation. and data retention. This is going to be very valuable to you when you do go under inspection. And sometimes the inspector doesn't really know what he's looking for or hasn't really formulated. And if you have all this documentation and data retention, it actually just many times they don't have to like really go through it that much because they see that you have done all this work. So just the fact that you've done it, you've documented, and you're monitoring it on a day-to-day basis. So the next slide, elements of H&E validation. And I have in the center the H&E Staining System, and I wanted to say that there's 3 or 5 different elements that I put in this presentation that will build, or that's the foundation of your H&E staining system, of validation your H&E staining system. The first is the stain. Of course, the dyes and the reagents. You have to validate whatever dye that you're using or reagent. If you're going to change from one company or one commercial vendor to another, you have to validate that again. So you have to show the validation that you've done on that it works and it's acceptable by your pathologist. And then the staining method that you're using, if you're using a progressive, regressive, or whatever, that should be mentioned in your validation of your stain. And I'm mainly, when I say stain, I'm just talking about the hematoxylin, the eosin, the xylene, the alcohols, or if you're making those up, you have to validate all of that. Just show how you've done it. The next is the stainer. And so you have to, of course, the stainer's name, but you have to show the protocol that you used on that stainer so that the stain that you're running every day is validated on this protocol, on this stainer. And then what you want to mention in there is the rinses, how you have that set up, the agitation, the dips. Also, you want to list a template. And template is basically just how you have all the reagents and the dyes set up on the stainer. So it's just like a snapshot of that. And then finally, the slide match trials. All these different trials that I got to get to the stain that the doctor liked, which is what we're going to do. Now, once we get to that point, we still have to validate, run validation runs on that. We're not done yet because you have to show reproducibility of that stain that the doctor liked. But that comes in later. But slide match trials, it's a one sheet that I'm going to show you. You can set up in a Word document of how to document and track all of the different changes that you made when you're going from one protocol to another to get to the final protocol that the pathologist likes. And the next is the QA monitor. How am I checking to make sure that my system is good and it works and it's approved? How am I checking to see that it's consistent from one day to the next? And so we're going to talk about developing or how to use a control block. And you make your slides for your validation run in the morning from that. If you're going to make that up, which I would strongly suggest, and I'm going to go over later, you want to show the tissue, how you get the tissue acquisition for that control block, and then your daily monitor, some kind of sheet that shows how often the stains were rotated or refreshed, changed new, or so forth, and then the maintenance on the stainer. Next, the technical review. The doctor, the medical director, or his designee that he's designated signs off on each one of these things that we're talking about. The stain, the dye is working fine. He signs off on that. Doesn't necessarily need to sign off on the stainer, but the protocol definitely. And if you're using a control block, that those tissues, we're going to talk about all this a lot later, but those tissues, the doctor or the designee has to approve that these are valid tissues to use for an H&E control. And then finally, the biggest part is documentation. We're going to have documentation, and these are all documents that we're going to create on the stain and reagents, the template, the trials and the validation runs, and then the review and sign off, and then the retention of data. So these 5 foundations make up a complete, comprehensive H&E staining system, validated H&E staining system. Next slide. Let's move first to the first foundation, which is the stain. Validating the stain that you're using, the hematoxylin, the eosin. So basically, you see 2 bullets here, and the first bullet, you just need one sheet to capture all of this information. In this information, you want to put the method of staining, whether it's regressive, progressive, or hybrid. I'm going to talk more about that later. Of course, the hematoxylin used, the company or vendor. You could even put, you don't necessarily have to put lot numbers down each time that you open up a bottle, but you just mainly want to document the stain that you use, the eosin that you use, and just in talking about those two, um, the hematoxylin and the eosin, basically, if they're prepared by you, you need to document that. You can put all of this into like one sentence, saying that uh, this stain was validated using hematoxylin XYZ with a regressive or progressive method of staining, and then a brief explanation of that, which I'll show you on the next slide. But you say hematoxylin used with regressive staining, where stain is applied and then differentiated. It could be like one sentence. Sometimes the reviewer coming in doesn't know all the details, but it shows that you have actually fully documented explicitly and specifically your stain. The same with the eosin. And then the third check on there is the reagents used and methods of preparation, if not commercial. If you are making up your 1% acid alcohol for differentiation, you need to document that and how you make it up. And it's just one or two lines. If you are making up your 95% alcohol from the 100%, you need to just have a statement in there saying that. So if you're using these reagents that are not commercially driven, if you're preparing those, you need to document that. The next bullet on there is the technical review and sign off of the stain performance. Once we've got the stain validated, we need to have that signed off on that he or she, the pathologist, likes the stain. They have to sign off it, or a designee. Now, I want to really strongly emphasize that you limit the number of reviewers, because as a consultant, I've been into places that had 10, 15, even one place 19 pathologists, and all of them had their own preference about what they liked. And so imagine trying to satisfy 19 pathologists, or even 10, or even 5. So you need to limit that down, hopefully, to 1 or 2. And that doesn't always happen, but it's going to be easier for you to validate a protocol or even come to a protocol. So the next is, this just supports validating the stain. I just put some basic information here to also show, and I'm going to go back one slide, this part about the method of staining, how you put this into your document, the one document. Now move forward. You can say I'm using XYZ hematoxylin under a regressive protocol method of staining, where stain is applied and tissue is overstained with the hematoxylin, and then a differentiator is used to aggressively remove the stain. So you can say all this in like one sentence, but this gives a little more meat to your validation, so that if an inspector comes in, it might be a cytotechnologist that you have it inspecting your laboratory, or it might be someone who's not in pathology, they're medical technologists. But this just gives them a little more information about what is regressive. And so the next slide is progressive, and I did basically the same thing. Hematoxylin stain is applied, tissue is stained with hematoxylin only to a point, because basically these are usually weaker, I wouldn't say weaker, but less stronger hematoxylins. Traditionally, no differentiator is used to remove excess hematoxylin. Stain procedure continues on with stain. Now, I'm going to talk about this third bullet more later, because they say that it's no differentiator used, but when you talk about some of these substrate washes that they do in progressive stains and some of the more modern staining methods, it's not really a differentiator like 1% acid alcohol, but acetic acid or acidic wash, citric acid, some of these things like that help sharpen up, but they do remove some of the excess hematoxylin. So in one sense, they're still considered a progressive stain, but truly it's like a pseudo-progressive stain, because you do go back and remove some of that excess hematoxylin, even if it's just a residual hematoxylin that's on the slide, not necessarily in the tissues. So I put this just to make this graphic show a little bit more simply. And I know this is elementary, but I'd like to actually make sure that whoever's reviewing our lab understands what we're doing. So I put that there, regressive and progressive stain, and some of the hematoxylins that are related to regressive stain, Harris's, and then progressive stain, Myers, Gills 1 and 2. Gills 3 is often used as a regressive stain. So next slide. We talked about hybrids. Now, why we have all these different hematoxylins, and I worked with a guy once named Russell Myers, and he was a great histochemist. And he actually, when training, working with him, he was telling me about these hybrids and what makes one hematoxylin a really strong one or different from the weaker one. Well, of course, they all have the hematoxylin powder or dye, but with the weaker hematoxylins, basically Gills 1, 2, and 3, and the Myers, you have aluminum sulfate, and then you have a lesser percentage of water, but you also have a higher percentage of ethylene glycol. Now, the benefit of these is that they don't oxidize as fast or hardly at all. So there's not really a need to filter these on a daily basis. I mean, it's a good idea to do it anyway, but it's not like you have all this precipitate building up from one day to the next. But on the converse, look on the far right side, you see Harris's hematoxylin, one of the strong ones. They have aluminum sulfate, but they've added ammonium. They have aluminum ammonium sulfate. Now, the disadvantage of this is that this ammonium precipitates out into crystals, and this is what you see at the bottom of your the hematoxylin container when you start to pour it into your stainer. You see these crystals at the bottom. Well, those are the ammonium salts precipitating out. And so that leads to this starts oxidizing almost immediately because of the presence of this ammonia. You see a higher percentage of water, but you see a smaller percentage of ethyl alcohol. So these are the main differences histochemically with the progressive hematoxylins on the far left and the regressive hematoxylins on the far right. So now they have these hybrids that they started coming out with maybe about 15, 20 years ago. And hybrids have qualities of both. And I don't really have, I mean, this is a proprietary product, so I don't really have the exact makeup of this. But basically, you take some of both from the progressive and the regressive, and it does have a residual ammonium content in it. But the benefit of using these are you can use them like a progressive stain, but you also will use something like a clarifier or something like that. It's a very mild citric acid rinse or something like that. It's not aggressive like what you would use in a regressive stain, such as 1% acid alcohol, but it's a very mild, but you still clean up the slide with it, and the residual hematoxin, like say in colon, you have in the goblet cells, you have a residual mucin, and these things help clean that up without really regressing. But it is somewhat of a regressive stain, just much milder. And at the bottom, I have some examples of some of the hematoxins that are under each one of these categories. So that's the difference, and the main difference in the hematoxins that we're using nowadays. And these hybrids are very beneficial because they save time. Some pathologists say, well, I still want my Harris, my regressive hematoxin, and that's their preference. That's fine. But these hybrids will give you a deep, deep stain, much like the truly regressive hematoxins. Next slide. Now, validating the stainer. The final protocol, which you need a page showing the final protocol, which shows the programming settings for the stainer that you're using. The rinses, if it's a flow rate and intensity of rinse, can and will affect the intensity of the stain. If it's a slight trickle coming through, it may not really wash out the hematoxylin, or when you're going from your bluing agent, it might not really rinse it out well enough. You still might carry over some alkalinity into the eosin after you rinse, if it's a very mild rinse, as opposed to like a really nice flush going through. I don't mean like washing the tissues off the slides, but a really good rinse. And then agitation, whatever setting you have for agitation, the number of dips, or any other program setting on this stainer. Because normally when we set up our stainer, we set it up to do this, and we don't change that. So, but you need to you need to document that and validate that as you're validating your stainer. The next thing is the template. You need to have an image of the template that you're using, how the reagents are set up on that stainer, not just what stains that you're using, but you need to kind of like, and I'll show you this in a second, you need to be able to show the template. Now, slide staining trials. We talked about that before, but as I'm doing all of these different stain trials on this stainer to validate my stain, I need to have a sheet to show that. And that needs to go based on these staining trials were used on this stainer. So this is the protocol, and this gives you an idea of the, I'm going to go back one slide, of the slide staining trials that I mentioned. So here you see on the far left all the reagents that we used in the procedure, the order that they're used on the stainer. The second column to the left shows the standard protocol. This is what we're using now in the laboratory. Now, as we're validating a new stain, you have the different columns that says stain trial 1 or ST1, ST2, stain trial 2, ST3. These just show you the different opportunities that you have to actually make adjustments. Now, I put in highlight the blue areas because you don't need to start changing everything. Basically, the deparaffinization process here is going to be constant. The rinsing, you might want to change that, but basically that's going to be constant. What you really need to focus on is the time and the hematoxylin, because if your hematoxylin is weaker on this new stain that you're using, you might need to extend the time. If it's stronger, you need to drop that out. The differentiation, maybe the differentiator is really, really strong, and you might not need 1 minute that you have on your present protocol. And then your time and your eosin, and your time in your 95% after eosin, because that residual 5% water in your 95% alcohol will start to pull the eosin out of the tissue. So if you leave it in there for like 2 minutes, as opposed to like 15 seconds or 30 seconds, you're going to have a lot more eosin bleaching out of the tissues. So this is just an example of one protocol that I used, or how you would set up your stain trials. This is the template from one stainer, and the point that I'm emphasizing here is how can be variability in the staining performance. Now, this stainer has smaller receptacles, and I believe the rinse was a much milder rinse, kind of like just slight flushing. And these wash stations, and it was set up such that it starts down here in the whole station, then it goes through the deparaffinization process of xylene 100%, and then 95, then 80, and then it starts going over to the water rinses. And then it hits the hematoxylin, then it goes to the next water rinse, then it goes to the differentiator, and then it goes to the next water rinse, and then the bluing. Now, quite obviously, this is a regressive stain on this, but this is what you want to set up in your validation of your stainer, this template. And you can just do this in a simple Word document. And then whenever you make changes to your stain or protocol, you want to change this. So now this is a picture of that kind of stainer. And first I want you to notice how there's not much room in between the slide and the receptacle. Up in the upper right corner, these are wash containers. And you can see it's not much room up there. And so if there's just a little trickle, and I'm not saying that it is, but if there's just a little trickle of water coming through, then it might be a little problematic rinsing some of the stronger dyes or reagents, dyes such as hematoxylin. You might want to rinse longer. And it doesn't mean that this doesn't work or this is not a good stainer. It certainly is. But it just means you might have to make an adjustment. So I'm mainly showing the difference between stain performance on different stainers. Next is the protocol used on a different stainer, and started using this protocol, and it wasn't quite what the pathologist wanted, and so we had to make some adjustments. But one of the main things that I want to show you here is the template. Now notice on the template of this stainer, these receptacles are much larger on this template, and I'm using some different reagents. I'm using clarifier, which is one of the milder solutions to help tone the hematoxylin. So this is a progressive stain on this stainer. Oh, actually, we set it up for a progressive run. It can do either one. But this is basically how this is set up. But notice the larger size of the receptacles. Now here you can see that. These receptacles are much larger through. So it can accommodate three racks of slides. And you really get a good flush going through this. And you really don't need to extend time on this, but that can be your preference. The former stainer that I showed works very well, so it's just a matter of preference, but I'm just showing you how different ones operate differently, and this stainer has larger receptacles and gives you really good flush going through. So this is the protocol that we ended up with. I don't know if you saw in the last protocol, we started, I think, with 4 minutes on the hematoxylin. But eventually we added different timing procedures so that the first run that you do, you might start off with 6, and you say, well, this stain isn't dark enough, or it's too dark. The differentiator is 1 minute. You might say it's taking too much out, so I might have to change that. But you do this run, you look at it in the microscope, and you say, well, I want to tweak this. So you go back and you tweak another one, and you look at that, and usually you can get it down to where you want it in about 3 different runs. So after that, you take these to the pathologist, and you let them decide which one they like best. And they might tell you to continue on to another stain trial, hopefully not. But if you have multiple people looking at this, I can guarantee you you're going to go into 4 staining trials, 5, 6, 7, 8. So once again, it's important to limit the number of reviewers with this. What you're going to be looking at after you come out of all these different stain trials is something like this. Worked with a company once when I set up a slide match project with them where customers would send in their stains, and I would actually try to match that protocol, if not or exceed it. But here's what you're going to see. Like on the top, you'll see one stain procedure with 4x magnification, and across from it 10x magnification. Below that, this is a different stain trial that was used, and you can see the difference, 4x and 10x. Looking on the far left, you see at the top it's much stronger hematoxylin. The one at the bottom on the left is not as strong hematoxylin. Now that's based on the preference of your pathologist. Uh, Many dermatopathologists, they want to see a much stronger hematoxylin in the melanocytes and so forth. But that's the preference of your pathologist. But this is what you're going to be looking at. And I'll show another one here, which is 20x and 40x. The top is one stain run. The one on the right and the left on the top is one staining run at 20x and 40x. And the bottom is a different staining run. So you're going to be making a difference in these staining runs as to what you prefer or what you think your pathologist would prefer, and then you take them to them for them to make the final decision. And when they make that final decision, that's what they sign off on. So this is again validating your stainer and your protocol. Now the QA monitor. Let's move on to that. So first, I want to start talking about, well, there's 3 bullets. Control block. That's going to be one of your QA monitors. The next is going to be daily QA stain and maintenance monitor. How am I checking it on a daily basis, and how am I assuring that it's reproducible and continuing to work the same way all through the day? And then last is the random QA slide review, which is optional. I strongly recommend that, but it takes time and it takes a person being pulled out or from the bench to actually review these slides that are going out. And I'll talk a little bit more about that later. All it is basically is you're reviewing a certain percentage of slides in every rack that goes in every folder that goes out. It can be like 5%, 1%, 10%, but you want to just basically keep an eye on the stain that way, and actually give you an opportunity to keep an eye on the quality of microtomy, because we want to see these things and perfect them or correct them if there's adjustments need to be made before we send them out to the pathologist. One of the worst things in the world is when I would get a call from the pathologist of something that we sent to them, and they would send the slides back to me, and I'm thinking there's no way that we should have sent this slide out. And we could have easily fixed that and recut the tissues. So on the control block, the tissue acquisition, the tissue that I use, the primary source for the tissue, which is basically the gross room. A secondary source for getting those tissues for your control blocks is cannibalized blocks, different blocks that you've had. And I don't recommend that, but I mean, you can use that. But for validation, I like to actually control all of this. I like to know the tissues that I have, that they were fresh when we used them, when we got them. I'd like to know how they were processed. So I like to kind of control all that. So once you've got those tissues, you want to test each tissue block separately before you assemble them, which means you run them through the processor, but you embed them in different blocks, whether it's skin, kidney, liver, so forth. Now, the reason for that is that I've done this before. You get all these tissues together, and you say, great, and then you embed them all into one block, and you have 4 or 5 tissues in one block, and then you do your microtomy and your stain, and all of a sudden you see 3 of them work fine, but one of them has some necrosis in it, some hemorrhagic tissue or something like that, and you can't use it. Well, now you have to go and to melt that down and re-embed it, so it saves time if you test each block separately before you decide to assemble them. Um, and then once you get the tissues that you want, you do control block assembly into one communal block. And once you've done that, then you do your stain and you get the technical review and sign off for that as a control block that you're going to be using for your H&Es every morning. And then the daily QA monitor and stain and maintenance monitor, we're going to talk about that in detail in a minute. But let's still get back to this control block, the tissue acquisition. Choose tissue types and inform the PA or the pathologist to retain the tissues. Because in the gross room, they're busy and they'll forget. Gross and processed tissues separately, histotechnologist controls this. Many times, the PA or the pathologist, they'll give me a huge hunk of tissue or something that's too thick that I don't want to run for my control. So I might have to go back and trim that. That's why I like to make sure that the histotechnologist is controlling this part of it. So you probably will have to go back and trim some of the tissues that they give you. Then you want to section, stain, and review each individual tissue block. As I mentioned before, embed individual tissues into a communal block. Once you have all the ones that you want, make them into one block. And then you section that block and stain it concurrently with the current tissue control block that you have. I've been into some sites where they have one tissue, and I remember once it was like a lymph node or a tonsil. It was lymph node, and so that's great for to look at, evaluate your nuclear staining, but it doesn't give you much information on the eosinophilic staining or the contrast. So you need something with multiple tissues in there. So technical review by the medical director or designee. Once again, limit the reviewers, and technical review of the validation runs, which you're going to use this control, by the medical director or designee. The validation runs are separate from you validating the control block or the runs that you do to come to the protocol that the doctor likes. Once you come to that protocol that the doctor likes, then you have to do your validation runs to show reproducibility and consistency. And then you get your sign off on all of this. So next slide. Here's just a note that I would put up because, as I said, this would be a problem because the PAs will forget. They're so busy. So I post a note like this saying that these are the tissues that I want: skin, kidney, liver, tonsil, lymph node, muscle. And then if you have a fat processor probably, so breast and colon would also be good to get that too. Because those are processed differently, but you want to show that this stain and the protocol that you're using is also good, validated for fatty specimens too. Now, you don't need to make two different blocks for this, but you can take 4 or 5 of these tissues, and you should have some breast or colon in there also within the skin, kidney, liver, whatever that you're using. And you make this into one multi-tissue block. So here's a tissue request that I would put out, and I would post this. This tissue request is for the purposes of standardization and validation runs on the new tissue processor unit. So we did this, made this control when we were not only testing our stain, but our new processors. Individual tissues will serve to validate tissue processing units on routine histological processing runs. And so now I give them specific instructions. These are the tissues that I want. I want 3 cassettes of each. And mind you, again, you'll have to go back and inspect that, and you might have to trim some of them. And then fat tissue, breast or colon would be most desirable. And then you specific instructions. Please place them immediately in 10% nutrient formalin and return to the pathologist to the attention of, and then I was the manager and so forth. So what you get at the end of the day is a multi-tissue control block such as this, where I have 5 different specimens here. I think this is kidney on the top, if you all can see my pointer, and I think the next was liver. On the far lower right, I think that was GI tract. And then in the center is skin. And then on the far left, lower left, it was tonsil, or lymph node. So this is what you want to develop. And you develop like 5 different blocks of this, and you just, once they've been validated, you just run those blocks and put them in a slide box. And then you have those as the control tissues that you run each morning or with your first run or before your first run. Some places like to do it first before, but you need to run it with your first run at least. So now on the QA monitor, on the daily QA maintenance sheet, here is a document that I created, very simple, just in Word document. And this will be a daily sheet that they fill out. And I couldn't get all this on the PowerPoint slide, but if you see over here on the upper left, this date, this will be at the top of this graph. And then lower on the left, you see change, rotation, schedule. This will be up under the graph. And so some labs that only deal with maybe 300 slides a day, they probably don't have to really worry about this change in rotation. But for other labs that are doing 750, 1,000, 1,500 slides a day, they definitely need to look at because something like this, or have something like this, because the stains are not going to perform the same from the first batch that you sent through to when you get up to 1,000. The alcohols are going to start to not be as pure. The xylenes are going to start to get some residual paraffin in them from the rundown or water. So you have to determine, and you determine this in your laboratory. Every 300 slides, we're going to rotate the alcohols and the xylenes. Every 500 slides, we're going to change the clarifier and the bluing. Every 500 slides, we're going to change the hematoxylin and the eosin. And like I said, you determine this in your laboratory. And so when you see in the graph here, you have to count slides. So some of the racks that are put in, they might not have all the slides. They might not be full. So the technicians would count the number of slides in there in the rack and write that down, and then the time that they put it in there. So if it ever came up where we're missing some slides, I can always go back and look and see where those slides went in at a certain time and so forth. And then on the other side where you see reagent refresh, this stays open until we get to like 300 slides or whatever. And then the person that does the rotation documents rotate xylenes and alcohols, and then they initial that. So now I can count the slides. Now if I go in one morning and I see that nothing over here in the reagent refresh has been filled out, and I start counting the slides in the column on the far left, and I see we're up to like 700 slides and nobody's changed anything yet. So now we have a problem. So this is the benefit of having a daily QA and maintenance sheet. Now this will get signed by the supervisor. You see the reviewer signature, and if you're doing a lot of slides, you'll have 2 or 3 pages to represent one day. This gets signed and retrieved by the supervisor and kept in a folder. So you have this verification for the reviewer to see if they come in. Next is the technical review and sign off. This is second from the last. The controlled tissue sign off. Okay, the doctor has to validate that this control is good to use. The protocol slide trials via the new control that you're using, that panel that I showed you with ST1, ST2. Now you sign off on that. You don't necessarily need to, because what you're just signing off on is that this was done. So you don't need to necessarily have it signed off by the pathologist. And then all validation runs, which is, as I said before, 3. Once you get to the protocol that you like, under the slide protocol trials, and the doctor says, this is the one I like ST4. Okay, so you have to go back and take that, and you do 3 individual runs to show reproducibility and consistency. And those are your validation runs. And once those are done, you can have the doctor sign off on those. So the documentation, this is the last thing we're going to talk about today. The documents that you need for your final documentation are the documents that we talked about on the stains and reagents page, the template, the stain trials page, the ST1, ST2, ST3, the validation runs that you did. You need a page for that to show a sign off on that. And then review and sign off page for the entire validation project. And I'm going to show you just examples of that. And then finally, the last is data retention. You have to keep all this data. So all the documents that we've just talked about above, and then stain control and protocol validation slides. The slides that we did when we, not all of the different trials, but the protocol that the control that we did, the staining that we did on you need to show the controls that were validated. I would keep those slides. And then the validation slide runs, those slides. So let's talk about some of that specifically. Now, this is an image of, this is the final document It says this document outlines the hematoxylin and eosin performance validation runs for the new automated stainer cover slipper for the Department of Histopathology. Construct. How's it set up? Well, I did this in phase 1 and phase 2, and I'll talk about phase 2 in a minute because I'm just very kind of like out of control when it talks about validation. But in phase 1, we have 3 separate independent runs of the routine stain hematoxylin and eosin were performed on the stainer, whatever stainer it is you want to name that, using laboratory validated existing multi-tissue tumor blocks. Slides contain specimens. So this is the specifics about how we did the validation runs. We did 3 runs, 3 separate runs. We did it on this stainer. We used a new tissue block and so forth. And this is what the tissues were in there. And then a control slide of the same type were also stained on the existing H&E stainers to show a comparison between existing and new stain performance. Now, phase 2 is something that I just did because this is fine. We validated this on a multi-tissue control block that I developed. I controlled that. I knew the tissues. Well, of course, everything should work on that. But let's take this validation a little bit further. So I did blind clinical trials. I took about 4 different cases, archive cases, and this reads, blind clinical samples were used for this live validation run. 4 different blocks were selected from blind clinical samples. I just took 4 cases. Tissues on the slides, respectively, were tonsil, endometrium, and uterus. 2 blocks of tonsil were submitted. So now this is just something that I did. You don't necessarily have to do this, but I wanted to assure that these didn't just work on control blocks that I controlled. These also worked and were validated on patient specimens. So the same basic H&E protocol was used on the existing stainer, same as I said before. And then you see the results. And so you just, I'm going to show you the results page in a second, but you just put a brief sentence down here, a paragraph about the results, and then you want to summarize it. You put something down here about the summary. We have validated this procedure based on this, and we're successful in this, and pathologist or medical director is happy with this, or however you want to state it. And then the validation concludes. You have to put a conclusion to this. Instrument and validated protocol will be integrated into routine daily use for the H&E staining runs as of, and you have to put a start date so that an inspector can go back and say, okay, as of this date, they started validating all of these stains using this procedure. So they can't really hold you accountable for something like a year and a half ago. We started this, and from here on, we're doing all these things that we talked about. Now, the other side, this is the validation runs that I mentioned. So the control validation at the top and the blind clinical trials. The control, this is the past control that we were using. And of course, the doctors have been using it, so they should put acceptable. And then the 3 different runs that we did of the other control, of the new control, the multi-tissue tumor control, C1, C2, C3. And so I wanted to keep this simple. So I just put acceptable, unacceptable. I didn't want to open this up where the doctors would score it 0 to 5 or 0 to 10 because that they can get complicated doing that. Just have them mark whether they accept it or approved or whatever or not. And then the blind clinical samples the same way. With this, I used the new multi-tissue control, and I did the 3 different blocks, 3 different runs on one of the blocks. And you have this signed off by the medical director, and the supervisor has to sign off on this also. Okay. So last is retaining the document. Now, once you've done all of that data, you put this into a document such as this, however you want to create it. But this is your binder for your H&E Staining System validation. The systems validation manual is what we have here. And so you put your hospital name up under it and so forth, and then the contents. But all of those things and those documents that we talked about are going to be in this manual. So when you get inspected, they say, show me your manuals. You know how the inspectors come in and do that. Well, this would be one of the things that you set out. And I'll tell you, a lot of times they're not expecting to see this because most people haven't taken their validation of their H&E stain to this extent. But I've never met one inspector that wasn't really impressed with this because I know that they're not getting this, something to this detail. And this doesn't take a lot to do. And really, if you're a supervisor or manager, when you come up with this and you're finished, you're very proud of it. You know, I've had inspectors come in and they say, okay, well, I see enough, and I don't really want to see that this. And I'm saying, well, no, really, you got to look at this. I'm so proud of what I did that I was trying to get them to look at something, and then I realized, they can find fault with almost anything, so I better stop right now before they look into it and see something that they don't like. But so inside this also is the slides that you want to keep. Now on the left, you see the slides of the controls tissues that I use, and you see how they're individually done and tested and approved. And then I put all of them into one communal block at the bottom on the left, same. And then on the right, basically we were talking about, I think those are the blind samples, but you want to retain these validated and approved slides that you ran, that you showed the doctor, that he said, great, this is what I like. So you want to keep those slides and you put those in this manual also. So this is basically the presentation that I wanted to show you all today. We have a few extra moments, I think, for questions, and I'm going to, in a second, turn this back over to our facilitator, Josh. But it's very important. I mean, this may seem like a lot of work, but it's not. And because we're working on patient specimens, we need to be able to give an assurance that these methods and procedures and the instruments that we're using and the dyes that we're doing are validated to run tissue specimens, especially if you're working in a hospital. But even if you're working research, working on animal tissue, but especially if you're working in a hospital, I am running these patient specimens, these patient tests, and here is how I validate that these tests work, that the stain works when they're diagnosing these patients. So I want to end up with just showing my reference page. I always like to give kudos to those who I used or borrowed from or assisted me in any kind of way, some of the resources that I use. So I leave this here, and I hope that some of you all have found something that is useful to you, even if not all of it, part of it, that you can implement into your staining system, once again, systems, and that you can develop an H&E staining system validation for your protocols. Very important. It's something that you'll be very proud of, and it's something that will help you document when you made changes, when you didn't, how long you've been using something, and so forth. So thank you all very much for attending. Also, I want to commend you all for your continued growth and development in the field. And I love teaching and training, and this gives me an opportunity to continue what I love to do, and you all give me an audience to speak to.